So when we increase the vertical, we get room for the restoration. We improve our maxillomandibular relationships. We can improve our overjet, our overbite. We can keep or we can improve our angle of disclusion. And improve also our facial aesthetics. That are the advantage of working with VDO. And this kind of complex case, when you have to protect and have to cover all tooth surfaces, it's a very important strategic decision, because with this strategic decision, you can save tooth structure, you can improve the relationships. Every time we increase the vertical, we can have a lot of advantage of this action. Here, step by step, the way you do, we have first of all the incisal edge increasing. We add some wax on the incisal edge. We add some wax on the buccal surface, trying to reestablish only the buccal surface. So far, we start by the incisal edge, and then we go to the cervical area. This is the things that we have to take care, that we have to evaluate when you're trying this as a mount. The buccal wax up is ready so far. This is the buccal wax up. We can look at that. So far, we only did the wax up on the buccal surface. And after doing that, this buccal wax up will be tested in mouth. It will be tested in mouth with a mock-up. This mock-up is a test driving of this buccal wax up. When you do the mock-up, you are testing the aesthetics and you are testing the phonetics. That's very important, because once it is approved, it will let the technician start developing the functional part of the wax up. So I have my point, my final point of my final incisal edge position, and once I have this position, we can start developing the functional relationship with the lower anteriors. Here we have our maxillomandibular relationship, and then we can finish the wax up now paying attention to the functional and developing not only the lowers but the lower posterior. Now we can check that everything is ready. From now on, our treatment is planned, so we have to follow our guidelines from this point. And now it's a question of tooth preparation. In this case, of course, we are in an era, we are in a time of minimally invasive dentistry, but we have to remember that this patient showed erosion, showed attrition, showed some abfraction, and showed some abrasion. So in a very acidic environment that, of course, should be referred to a specialist to be treated well, but we have to protect this tooth structure. Protect doing some kind of very minimally invasive preparation, but it should be rounded. It should be provide a 360 degree of tooth protection. So we did some conservative tooth preparations. We can see by transparency that some parts of the tooth weren't touched at all. I tried to keep all my margins in enamel, trying to keep all my finishing lines around 0.4, 0.5 millimeters of thickness, trying to be minimally invasive but working at 360 degrees. Here we can see that as we increase the vertical, we didn't have to do the preparation on the occlusal surface. We did this acrylic temporary overlays to give the support for the mandibula to restore a proper maxillomandibular relationship. And if you take this acrylic temporary overlays off, we can measure it, and you can see that you already have 2 millimeters. So we didn't have to touch my occlusal surface, which is very good biologically speaking, because if you don't touch the tooth, that is already eroded edge, which is already treated, we are going to protect them because you don't have too much thickness. Otherwise, you're going to have an endodontic problem because it's very close to the pulp chamber. So here in the provisional evaluations, we can see that the provision is a little bit yellowish. It's yellowish because we can see by transparency the color of the cement. The color of the cement, of course, I did it on purpose to show how thin my provisionals are. If I don't want to show, we can use like a transparent provisional cement, but here we can observe that it's very thin, and when we finish our case, we can do a very thin porcelain cement with a cement with a nice color, and we're going to have a very nice result. So this is our provisionals. Now it's time to do some fine tunings in the anatomy. So we're going to correct our intradental proportions. The tooth so far is a little bit square. So as the patient is tall, the patient is strong, we thought that the patient deserves a taller tooth. So in a relationship around 90%, we evaluate and when you plan it to reduce it to an 80%, so the patient needed to undergo a very slight periodontal plastic surgery. Here we're probing our initial plan, our actual result. So we refer that to a periodontist who did a flapless surgery. This is Paulo Carvalho. He did a flapless surgery only to correct the zeniths, only to increase the size of the tooth by around 2 millimeters. Now you can see the difference of the result, and after changing the provisional, the difference of tooth anatomy that we got so far. Here the case already finished with all the tooth and the position. So the case, when you cement the case, of course we do a very precise occlusal equilibration before the cementation, but after the cementation is very important to fine-tune the occlusal equilibration. That's very important. That's the procedure that will make the treatment to last. So you have to take care of that. And how do I do that? Well, I like to use different types of articulating papers. I like to use different articulating paper because it saves time. Depending on the case, depending on the point I am, I can use a 200 micron articulating paper, I can use 100 micron. When I'm finishing the case, I go to a thinner articulating paper like a 221 micron, and I always finish the case with an 8 micron shim stock. That's just to check, this is to really fine-tune my occlusal equilibration. So this is the point we begin. When you talk about the recommendations about occlusal equilibration, you have to remember that the first one is equal intensity bilateral simultaneous contacts. But in CR or in MIP, in this case, as I'm doing a rehabilitation, of course we need to work with the only reference position, predictable and stable reference position that we have for this case, which is CR. But why should we adjust the patient in CR and with equal bilateral simultaneous? It's good for the articulation, of course. It's good for the articulation because we have a nice direction of force, and always for the restorations, because we can, if you work with this bilateral simultaneous contacts, you share the load between all the posteriors. From canine to posterior, you share the load. So this, if you take a look at the literature is very vast, and the papers doesn't have a very precise value of occlusal bite strength. But if you look at the literature for the most important papers that were published during this time, we can see that we have a variation of the tooth force depending on the area of the mouth. For example, on the anterior teeth, you have a bite force of around 100 newtons. And on the premolar areas, you have a force bite of around 560, and on the posteriors around 900 newtons. If you look at the same chart but emphasizing different things, you're going to see that we have a 1/9 relationship. What I mean is the force on the posterior are quite bigger than on anteriors. It can work well for us because on the anteriors we have some shear forces, and as we have forces with less intensity, is going to be good for the durability of our restorations.